Today's presentation is on the topic of syncope and dizziness, which are quite common problems in the older adult population. So we want to get a little handle on those two clinical conundrums, if you will, and see what we can come up with in terms of assessment and management. So our goals today are to report why the loss of consciousness may occur amongst older adults. Of course, it occurs with all ages, but it does have as we'll see, the epidemiology, a little higher prevalence in the older adult population. We'd like to define how to work up syncope, and then we want to talk about the treatment. So just a very basic approach. Syncope is by definition is a transient loss of consciousness, and it's generally due etiologically to brain hypoperfusion. In terms of the epidemiology, syncope is very common, as I alluded to earlier. 30% of all adults will have some sort of fainting spell over their lifetime. And it does increase with age, and it is one of the top reasons for an emergency room visit in the 65 and older. I would like to mention that I've been on several flights, traveling, and it seems like every fifth flight or so, somebody faints on the airplane. And so, of course, they ask, you raise your hand if please identify yourself as a doctor. And so I've done this several times, and it's very interesting in the airline response. Some of them are very accommodating with requests that I have for like a blood pressure cuff and blood check, for sugar and so forth. And then I had one flight, it was a transatlantic flight, and the airline attendant decided that the young man who passed out had too much to drink, and so he really didn't need a doctor. So I've found that kind of interesting that the airline stewardess took charge of the situation, and as it turned out, she was right. But as a provider, you always have a little differential diagnosis going, and you raise concerns for, like, did the person pass out and actually die? It's like, do I need to do CPR? But anyways, that said, different experiences on the airlines for sure. So syncope occurs in different settings, and in the long-term care setting, there is a lot of syncopal spells. One study showed a 6% annual incident rate, and then of those that actually fell with a from passing out or loss of consciousness, that a third of those people will have a reoccurrence. So it's a big deal, as people are in long-term care, and we'll talk about some of the reasons why older adults are predisposed to this condition. So here is a chart of the frequency of falls per 1,000-year, life years of the population. And you can see basically two spikes. One is in the basically very young adult time period, and then the other one is over the age of 65, and you can see graphically how that looks. But bottom line is that people over the age of 75 have the highest rates of fainting than any other age group. One of the data that comes out and strikes me is this Irish longitudinal study. It's called the TILDA study, and they paid a lot of attention to this concept of syncope and falls, and you can see that the percent of older adults that are both have syncopal episodes and falls in Ireland was significant. So the 75-year-olds and older, you can see on that bottom line there that they had about 1 out of 4 older adult individuals will have a fall during any particular year. So it is quite common. So in terms of why syncope occurs, if we look at the pathophysiology, There are a variety of reasons that may contribute to this. Sometimes they're, and usually they are multifactorial. So drop in blood oxygen, changes in heart rate, either elevation in heart rate or a decline in the heart rate can precipitate syncope. Rapid changes in blood pressure, as well as blood volume. So you can imagine that somebody, for instance, that has a bleeding gastric ulcer may lose an awful lot of blood, and they may have a syncopal episode as a result of that. Cerebral blood flow can occur. Usually the issue for passing out from cerebral blood flow is that both sides of the brain need to be affected, and so most commonly those are in the back of the brain. And so it's not that, you know, the cerebral blood flow on one side of the brain is going to cause a passing out spell. And then finally, just the multiple comorbidities that can all conspire together to contribute a syncopal episode. So it may be a combination of low blood pressure that then precipitates a heart arrhythmia, or vice versa. And so you can see that there's an interchange between these different factors that can contribute to the episode of syncope. So we know that as we age, there's parts of our physiology that predispose ourselves to syncopal episodes. Those include the carotid barrel reflex. You know, so basically there's receptors in the neck that sense when blood pressure changes occur, and that they're often blunted, and they're not as sensitive. And so as a consequence, when you're challenged by, let's say, standing up from a lying or sitting position, those receptors aren't going to sense that change as rapidly, and then therefore the neurologic system can't respond as quickly. And so between the interceding recognition of the event by the body and its response to it tends to be seconds to minutes, and as a consequence you can have an intercedent syncopal episode. The other issue that comes up is that second point there about low blood volume, where the kidneys get rid of salt, and that's not always the case, because at least in American diets, we overconsume salt. We on average take 4.3 to 4.6 grams of salt daily, and we only need half of that amount, quite honestly. But anyways, the point being is that with low blood volume, the body, as we age, doesn't really respond well with plasma renin levels and aldosterone, which are hormones that are meant to say, hey body, take on more salt. The heart itself may have decompensation, particularly, as we'll see, there's two components to heart problems in the older adult. One is the squeeze, which is the systolic portion, and the other one is the acceptance, or the relaxation. So that's called diastolic dysfunction. The other problem is that the aging heart rate is not responsive to stressors, and so it's very sluggish and slow to compensate with any type of stress. And so again, going from that lying to sitting position, we'll see some data about that. And so as a consequence, you get what's called orthostatic blood pressure changes that we all get, quite honestly. So if you were to lie down and rapidly stand up, you know, from the lying position, you would become orthostatic, but that is just very transient. It will only last for a couple of seconds at best. Whereas in the older adult, those seconds turn into more seconds or minutes, and then as a consequence, they get low blood pressure.
So the next slide that we see here.
So there was a question really quickly.
Yeah,
Can
sure.
this happen when standing up quickly, or is this different from orthostatic hypotension?
Well, orthostatic hypotension is the sudden drop of blood pressure that can cause dizziness or symptoms, either from a lying to sitting position, or from a lying to standing position. So no matter how you do it or how quickly you do it, it can occur, and it can occur slowly. Like if somebody gets up out of bed and they're, you know, kind of struggling and trying, and they finally get up, they still may have orthostatic hypotension. You know, so it really depends on the individual and their physiology. So yeah, I hope that answers that question, and that's why, as we'll see when we do the what we call orthostatic blood pressure check, we always have the person lying flat and then either sitting up or standing up, and then or if they're bedbound, we'll have them lying flat and then we'll dangle their legs over the side of the bed. So just getting back to, were there any other questions at this point, Rebecca?
No, there were not.
Okay, very good.
Thank you.
Yeah, and I'm perfectly fine with answering questions as we move along here from the chat box. So thanks for the alert. The causes of syncope in older adult are outlined here. These are the main ones. And I would say that the vast majority really become the lower right-hand box there, the multifactorial etiologies. So, but we have the reflex syncope, we have orthostatic, which we were just talking about, cardiac arrhythmias, most typically either heart block or rapid ventricular responses to atrial fibrillation, for example. We also have syncope caused by blockages in the valves, you know, so sometimes the heart valve gets narrower and narrower from fibrosis or other reasons, and that can cause syncope. And then we talked about cerebral vasculature, and those are typically loss of circulation in the what we call the posterior circulation, which are the back of the brain, involving the basilar or vertebral arteries. And sometimes you can get a sense of whether somebody has vertebral basilar artery insufficiency when they lift their chin up and they start getting lightheaded. So that's actually a clinical maneuver that we'll use. So good news, bad news. 40% of syncopal episodes are undiagnosed after we do a complete cardiac workup. I'm reminded by this Jackson Pollock of the, you know, the splatter art that we have, and I'm also reminded and very proud of the fact that I was working with my 8-year-old grandson with his birthday over this past weekend, and I bought him some squirt paint, and he was making Jackson Pollock like designs on big pieces of paper, which is the good news. The bad news is that his 5-year-old sister got a hold of one of the squirt bottles and painted him and herself in black paint. So we had black paint all over the house. As you recall, one of the 6 components of syncope involves reflex syndrome. So these are most classically in the younger population, that first one, which is called the vasovagal faint. You know, that's where the vagal nerve gets hyperstimulated and causes the blood vessels to dilate and people pass out. The other one is carotid hypersensitivity syndrome, and that's where motion or touching the neck or tight-fitting collar might hyperstimulate the carotid sinus, which then puts the heart rate into a very rapid response, and you get a drop in blood pressure. There's other, you know, what we call situational fainting. Those include a variety of things. Sometimes just you know, having a bowel movement or straining during a bowel movement might cause a syncopal episode. For older adult men, sometimes problems with urinating, what we call post-micturition syndrome, where they just have, because of prostatic hypertrophy and outlet obstruction, they have problems getting their urine expressed, and possibly because of the dilation of the bladder, they get a reflex response and this, you know, fainting spell basically. And then really intense pain can cause reflex syncope or fainting. You'll have this as somewhat of a protective response in some cases, but in other cases, depending upon your pain threshold, it can be maladaptive. This is a big one. I really want to emphasize that this is something that is fairly easily diagnosed. It's called postprandial hypotension. And this occurs typically in the very frail older women. They're usually recognized as somebody that looks like they're anorexic or really have lost a lot of weight. And it'll occur typically a half hour to an hour after eating a reasonably moderate to large meal. So in assisted living facilities or in nursing homes, that may often be the midday meal. And if you have somebody that is taken back to the room and they have a fall or actually a passing out spell, it could be due to this phenomenon of postprandial hypotension. And we can talk a little bit later about how to recognize that, but I think basically you connect the meal time with the episodes. That's always important why we ask in the history as to, well, before you fell or passed out, when did you last eat? And that's also a good question for diabetics because if they are hypoglycemic, you want to know that. But also you want to ask the same questions when you passed out. When was the last time, or at what time did you take your medications, right? So connecting syncopal episodes between meals and medication are an important part of the history. So orthostasis is that phenomenon of a drop in blood pressure, usually defined as 20 millimeters of mercury for systolic drop, or 10 millimeters of mercury for diastolic blood pressure drop. And the phenomenon is often associated with age, more typically medications, and the big one is autonomic failure, and that's things that you see in Parkinson's disease, or what we call Shy-Drager disease, which is a syndrome. Shy-Drager syndrome is defined as autonomic neuropathy, where the internal nerves don't work so well, and you can't really control your blood pressure very well. And then finally, which is often common, particularly in Alzheimer's patients because they forget to drink water, is volume depletion. So here in Grand Forks, where we work with our GWEP with one of the long-term care groups, and they were in their assisted living facilities, we're doing refreshment rounds, so they were offering soup and refreshment drinks, liquids for people on a regular basis throughout the day. And they found that by doing so, they had fewer falls, and they also had fewer, believe it or not, urinary tract infections. So hydration is really important. So the arrhythmias, as I had mentioned, there's both the slow heart rate and the tachycardia, or the fast heart rate. And these can be associated with atrial fibrillation or heart block, but you can also have episodes of what's called SVT, which is supraventricular tachycardia, and what we would call prolonged episodes of ventricular tachycardia. And these are often picked up on what we call the ZEO patch or Holter monitor. And as well as the other option is that you have pacemaker malfunctioning. And so these all need to be considered as part of the differential diagnosis. And I think the comment from one of our participants about they're liking the artwork that I've included in this talk, and I'll just comment every once in a while. This painting by Winslow Homer is one of his paintings that shows the desolation of a post-storm, which he was always very thematic for him. And Winslow Homer apparently, not that I'm an art critic or anything like that, but he apparently got criticized a lot because a lot of his paintings really showed very little hope of survival from the sea. And as a consequence of that criticism, he would periodically paint a little sailboat on the horizon to show that maybe there was a ship coming to rescue these, people that were stranded on the beach and so forth. I had mentioned that aortic valve disease is an example of, stenosis, where it's narrowing of the aorta, can cause syncopal episodes. There's others such as obstructive cardiomyopathy, which basically means that the heart is too thick, and as it squeezes down, it occludes the blood flow. And these are often called idiopathic hypertrophic stenosis is the old terminology, but now they call it just simply a cardiomyopathy. And then the wrapping around the heart can get stiff and fibrotic, or it can have an infection with due to pericarditis, most commonly viruses, and COVID is actually one of the viruses that can cause this. It's unusual, but any virus, a lot of times Coxsackie virus and these so-called stomach flu viruses can cause a pericarditis, and that's again inflammation around the heart, as well as other issues that block blood flow. So a pulmonary embolus and or pulmonary hypertension. So high blood pressure of the pulmonary arteries both can contribute to loss of consciousness. And then finally, a myocardial infarction can stun the heart, particularly with massive myocardial infarctions, and people will go to the ground. Sometimes there is what we call loss of consciousness. It's not syncope per se, because it doesn't necessarily deal with the blood pressure changes or obstruction of blood flow, but rather related to central nervous problems such as epilepsy. So you can have a generalized seizure and fall to the ground. Many of us, I think, in the health field have witnessed generalized epilepsies, and with what appears to be a fainting spell, they go to the ground. You can also have issues, as I mentioned earlier, about what's called VB insufficiency. That's vertebral basilar artery insufficiency. So those are the blood vessels in the back of the neck. And then finally, we can have metabolic disorders. So most typically, this is related to low glucose. So that's why we always want to check blood glucose on somebody that has a fainting spell. But it can be due to other reasons, such as a elevated calcium level, for example. The initial workup is, when you have somebody that complains of having passed out, or sometimes they'll say, I don't know if I passed out. I mean, that's been my almost go-to, history response from many older adult patients. They say, I don't know if I passed out or not. And so you want to document that as part of your history and physical. Whether there was any preceding aura, did they know that they were going to pass out, or did it just happen all of a sudden? Because if they have an aura, for example, and they felt like something was coming on, that may actually suggest more of an epileptic event than a cardiac event. The second point there is the orthostatic blood pressure check or blood pressure changes. And so you can see here that there's an individual in the picture lying down and then either sitting or standing. Typically, when you test for orthostasis, you go through all three positions, but quite honestly, just simply going from the lying to the standing position will reveal a drop in blood pressure if it exists. And importantly, when you take the blood pressure, that it be done at heart level, as you can see in the supine position here, and then with the standing position that you hold the arm up at the heart level. Some of the other interventions, but diagnostic workup may include a ambulatory pulse oximeter. I typically will walk somebody for 50 feet and see if their oxygen goes down as a consequence of their walking, or alternatively, sometimes their heart rate goes up very dramatically, and that may be an indicator of a malfunctioning heart, pulmonary embolism. If you see somebody that comes in with a very high heart rate, the first thing you always have to think about, if they complain of a fainting spell, the first thing you have to think about is whether they had a pulmonary embolism or not. And then just, of course, the EKG or ECG for checking arrhythmias. And I'm sure you've seen these commercials for Cardia, where you can buy this little finger length device that you can put your two fingertips on, and it indicates whether you have a sinus rhythm or atrial fibrillation. And not that I'm endorsing that as a product whatsoever, but I did advise my sister-in-law to get this, because she was having these kind of goofy feelings when she was walking. And I said, "Oh, just get one of those little devices and check your heart rate." And sure enough, she discovered that she had atrial fibrillation. And I just learned recently here that she had some procedure to reduce the arrhythmia. And then finally, the other test, which I don't really recommend, is doing a carotid massage. And the reason is that you don't want to do that and leave it to a cardiologist, is that sometimes people will have plaques, and you don't want to cause a stroke. So that kind of test is best left to the cardiologist to do. Some of the strategies that we have for evaluating syncope is, again, to look at the cardiovascular, which is mostly what we do, but then we also want to look at the neurologic system and ask the question, are there what we call autonomic dysfunctions? And so the autonomic dysfunction might be something like that person also happens to faint, as well as having chronic constipation. Well, that indicates that the autonomic nerves aren't working so well. We also have to take into consideration, and not always as frequently found, but our psychiatric issues, and just sometimes self-neglect in the older adult population. Again, not drinking enough fluids can predispose them to passing out. So if you do suspect, EKG is the same as ECG or electrocardiogram. So thank you for putting that in. So if you think that this is cardiovascular related, you want to get either a Holter monitor or a Zio patch, and also consider a echocardiogram. And from there, if there's some evidence of cardiac arrhythmia, there may be a referral to electrophysiologic study, so that's called the EP study. And then if nothing's found by then, and again, typically this would be handled by a cardiologist, would be to look at whether a carotid massage of the neck, or doing a tilt test as seen in that picture there, and or doing an adenosine provocation, to try and induce a cardiac arrhythmia. So those are all the different tests that the cardiologist may do. And then the final step is to do a prolonged ECG. And a lot of times you have to go for 48 to 72 hours, all the way up to weeks, for detecting it, because it's when the heart goes into an arrhythmia, it's very infrequent. And I also want to mention, some people say, oh, that we know that person was drinking like 10 cups of coffee a day, or drinking 8 bottles of Coke or whatever. Caffeine per se is not considered an etiology of cardiac arrhythmia. So I just wanted to share that thought with you. And so if you think the nervous system is involved in the syncopal episodes, again, this should be left to the experts, but again, doing the adenosine provocation test and doing a tilt test, and then getting still, as you can see, the cardiac evaluation, which includes an echocardiogram and a Holter monitor, or Zio patch, which detects arrhythmias. Yeah, so this is just an example where adenosine is injected, and it causes transient atrioventricular block, and you'll see this pattern of just those little P waves, or the atrium going into flutter or fibrillation, and then the medication wears off, and then the person goes back into their arrhythmia. And the key thing is that you always want to ask the person, are you feeling any symptoms when they go into that particular arrhythmia? And of course, if you do go into that arrhythmia where you just see the P waves there, that could be an indicator that the person is predisposed to atrial fibrillation or flutter. So orthostatic hypotension, as it turns out, whether you have symptoms or not, up to a third of community dwelling older adults may have, and when checked, a drop in their blood pressure when they go from a lying to standing position. And I mentioned earlier about the postprandial hypotension. This occurs a drop in blood pressure as a result of eating a large meal, and that can occur in as much as 1 out of 10 older adults in long-term care. And again, that frailty factor, that person that looks like they're sort of withering away, that amplifies the issue with low blood pressure. Part of the reason for all of this is that age itself reduces the heart rate recovery once you go into that upright position. And you can see the percent of individuals. So in middle-aged adults on the left-hand side, less than 10% of them will have a problem, going from a lying to standing or sitting position. But then look at the 80-year-olds on the right-hand side there, up to 40% of them have some issues of getting their blood pressure back up to steam, if you will, after they go from a lying position and getting up. High blood pressure will really exacerbate your risk for low blood pressure. And part of the reason is that a lot of older adults are put on evidence-based medicines such as hydrochlorothiazide or chlorothalidone, which are diuretics. There's also the stiffer arteries. So as we get older, the arteries become less compliant. And, for all those reasons, we can see that the blood pressure regulation really goes from very high to very low. And it's interesting that there are studies, including research from University of North Dakota, from our research, that shows that the really wide swings in blood pressure, that variation, is highly predictive of bad events in older adults. So we're looking more and more into this, and particularly with the long COVID syndrome, that long haul syndrome, because we're also observing that a lot of our older adult patients are having increased numbers of falls post-COVID, and there's a variety of reasons for that. There's a recent study that now showed that post-COVID long haul syndrome has low perfusion of the brain, of which nobody knows what the significance of it is and whether and how long it'll last. But basically, low blood circulation in the brain and low metabolism have been observed in long COVID syndrome. So in taking the history, you want to ask about orthostasis related to what did they feel dizzy? Did they feel lightheaded? Was there any blurry vision? Also hearing problems. Sometimes people either say, they'll have a gap in their hearing or they may hear ringing. And then also issues related to accompanying back pain. Part of the reason for that is that if you have a heart attack or an aneurysm that's caused the syncope or syncopal episode, that may be manifest primarily through back pain. And also you want to find out if they have any forms of leg claudication as well as chest pain. And in the older adult, as a reminder, they may not say chest pain, but they may say, well, I just got fatigued or short-winded. So those are non-specific signs of or atypical manifestations of cardiovascular etiologies of disease. So I had mentioned earlier about the autonomic nervous system getting screwed up. And so there are these syndromes of just pure autonomic failure. There's a condition called multiple system atrophy, which is fairly rare, but it does occur where the nervous system falls apart. And then probably the most prevalent is what's called the Shy-Drager syndrome, and that can be associated and frequently is associated with Parkinson's disease. So just to talk a little bit about pure autonomic failure is that it's detected by orthostasis. They may have problems with sweating, erectile dysfunction, bowel problems such as constipation and or diarrhea. And it often is associated with low plasma catecholamine levels. So that would be epinephrine and norepinephrine blood tests. multiple system atrophy. As you can see there in the right column, that there are not a lot of cases, but there's a variety of symptoms. And I guess just to relate it, that it's mostly like Parkinson's-like in its manifestation. And it is a condition that's associated with middle age, 50 to 60-year-olds. And then at its onset, it has a very somewhat short lifespan. In Parkinson's patients, it's always important to check, their blood pressure. So their medications can cause orthostasis as well as their disease. And so that's an important consideration, and to be aware of it, and then to work around it in a variety of ways, either through medication adjustment or adding compression socks, or just simply, asking the patient to slow down and not get up so rapidly. A lot of times they can't because they have motor slowing. But again, just taking measures that will help them avoid the orthostasis associated with their with the Parkinson's disease. So, not surprisingly, medications, and you may have gotten that concern in the pre-test question here, is that things like alpha blockers and diuretics or vasodilators, which include nitrates, and that's one of the reasons why they say don't take nitrates with the Viagra, right? Because it causes a massive drop in blood pressure. But mostly the blood pressure medicines are contributory to lowering your blood pressure, and sometimes they do a little too good of a job. And then there's a handful of antiarrhythmogenic medications. Amiodarone, a famous one for causing syncopal episodes, but also beta blockers and lidocaine-like medications. And just as a reminder that the antidepressants can cause syncope, tricyclic antidepressants. And then I put a picture in here of delirium tremens alcohol from Belgium, but alcohol can cause syncope. So some of the treatment options are, if you know what's happening with, say, a blocked valve, you can open up the valve, either replace it or do dilation. Usually dilation doesn't work for a long term. If there's a cardiac arrhythmia or a heart block, you deal with that either with a pacemaker or with medications. If there's uncertainty in what we would call a multifactorial etiology, you want to make sure that the older adult has good hydration. Probably need to look at the medications and see if there's an opportunity to deprescribe a medication, or maybe switch over to a different class of medication. And then also certainly to wear compression socks, which are tough. Quite honestly, older adults, particularly if they have arthritis, have a tough time putting on compression socks. So sometimes you have to find opportunities for older adult assistance, home health tech or home health aide or family member to help the older adult put those socks on. And the big thing is just don't lie around. The astronauts uniformly get orthostatic hypotension, right? And it's because they're essentially lying in space a lot in their chairs. Plus, there's other anti-gravity issues that go on. But yeah, if you're resting in a chair for most of the day, you're going to predispose yourself, and as well as in the hospital. Like if you're in the hospital bed for 3 to 4 days, you're going to start getting orthostatic changes. So the other part of orthostatic management is to avoid large meals. Don't overheat yourself in hot showers or hot tubs or hot weather. Try to avoid straining during having a bowel movement, or if you have problems with urination, to get medications or get an evaluation for the etiology of that. Remember that issue with alcohol. I call it the 2-for-1 rule. Basically, metabolism decreases as we get older, and so that one mixed drink or that one martini may turn into 2 martinis equivalent, for the older adult. And then you can see the other points there. The main one at the bottom there of avoiding dehydration, particularly during hot weather. Other opportunities are to use abdominal binders. or thigh high or waist high compression socks. Physical conditioning is really important to get more lean body mass. You can also habituate the orthostasis through postural training. So it's basically lying flat, tilted up, lying flat, going back and forth. And then in this instance, if salt intake might help, and again, to do so only in the absence of systolic heart failure.